The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device. Welcome to Spot the Bleed, an American Heart Association ICH Guideline Refresher Series, the podcast dedicated to providing comprehensive insights in hemorrhagic stroke care. I'm your host, Sue Abel, Program Consultant at the American Heart Association. We're excited to bring you content that addresses guideline-directed care across the continuum, from patient diagnosis, treatment, and all the way through secondary prevention. In each episode, you will hear from our clinical experts as they break down the ICH guidelines into tangible offerings. Thank you for joining us today as we aim to equip you with refreshed knowledge to enhance ICH care and drive positive outcomes. Let's get started.
All right, so I'm Tom Grawey, and I'm here with Nikolai Arendovich and Kevin Young. And today we're going to talk about the pre-hospital and interfacility management of intracranial hemorrhage patients. So I'm going to have my two counterparts here introduce themselves. So Dr. Arendovich, why don't you tell us a little bit about yourself?
Hi, my name is Nikolai Arendovich. I'm an ER physician and EMS physician in the Chicagoland area. It's a pleasure to meet y'all.
Great. And Kevin, how about you?
Hey, my name is Kevin Young. I've been a flight paramedic for about 9 years now, and have now since started medical school, so second year med student. Before that, did some ground EMS stuff with the fire department, so firefighter paramedic.
Great. And I think I forgot to introduce myself, but I'm Tom Grawey. I'm an emergency medicine and EMS physician over at the Medical College of Wisconsin in Milwaukee. So yeah, we're really excited to be here to talk to you guys about this pre-hospital interfacility management of intracranial hemorrhage. We've got Kevin, who's got a lot of experience in flight, and again, myself and Dr. Arendovich being EM docs who also do EMS work. Hope we can share some good information for you. So let's get started. So Kevin, you're called 911 to the scene of an 80-year-old female who's complaining of altered mental status. She woke up this morning and was complaining of a headache, some nausea, vomiting, which her husband attributed to the flu. She was recently at a birthday party for her granddaughter, and there were a ton of sick kids running around. But over the past 2 hours, the patient has now developed some left-sided hemiplegia and hemisensory loss. Her blood pressure is 224 over 106, heart rate's 112 and irregular, and her pulse ox is 98% on room air, and she's breathing at 22 times a minute. So when you're presented with this case in the pre-hospital setting, what are you thinking for your differential diagnosis of what could be going on with this individual?
Yeah, so this is a pretty standard start to a 911 call that it's not abnormal. An older female woke up with a headache, some nausea, vomiting, and then over about 2 hours developed that left-sided weakness. And some sensory deficits. So definitely, we start thinking about neuro things right away, and then taking vitals. You see she's significantly hypertensive, little tachy. That irregular rhythm too is somewhat concerning. So obviously, kind of makes us think neuro stuff right away. But we don't want a tunnel vision on that right away. So I think we're going to start doing like our stroke assessments and everything, and have kind of a sense of urgency behind that, but also then making sure that we're considering anything else too. If there's any recent trauma, any other illness besides what might be going on this morning or today, other significant medical stuff going on.
Great. So yeah, I think you got a pretty broad differential, and you've got to narrow down, to the likely things up front, which is great. You mentioned doing the stroke assessment. What other things do you think that in the, pre-hospital setting that you would do for this patient to help with your assessment?
Yeah. So anytime we have any neuro thing, if it any chance could be a stroke of any sort, we really need to know that last known well time, right? So pre-hospitally, that's really one of our biggest jobs, is to get a good last known well time, get a good history on the patient. because we're the ones that are out there and able to kind of get that from whether it's patient, bystanders, family members, whatever. So knowing when that was that they were last totally at their normal and what their normal is, I think is super important to keep in mind too. If they've had previous, head injury, stroke, things like that, knowing what their baseline neurostatus is and what's different now. When were they last at that baseline is super important. But yeah, so remembering things that other big stuff like hypertension, cardiovascular disease, all that, that could all be important risk factors that we need to keep in mind for a stroke that's going on here. And yeah, what medications and stuff are they on too is another really important thing, especially in these types of patients. We're again in a unique spot or important spot pre-hospitally that we're at the patient's house a lot of times or wherever else we are, that we're able to get a lot of good information that we need to pass on to the hospital. So what's their med history? What pills are they taking? When did they take them? It's super important. And obviously, when talking about stroke stuff, really focusing on things like blood thinners. So it used to be just, aspirin, warfarin stuff, but now we've got to keep in mind everything else: Plavix, Brilinta, Xarelto, Apixaban, all the different things now that they may be on are all super important, especially in stroke. So getting a good medical history and medications is big for this patient.
Great. Yeah. And I think you made a good point. Looking for blood thinners isn't as simple as it used to be. And,
right.
I think the other thing that this kind of reminded me of is a lot of times like paramedics will come to me and they'll be like, "Oh, doc, it's not that important that we bring, the meds or a medalist with us to the hospital because you guys have all that in the computer." And I can tell you that we do not have it in the computer. Most patients are seeing, with a lot of medical problems, are seeing many different doctors. And I will tell you that very often the medication list in the computer is not the most up to date because they might be seeing different doctors in different health systems. So, please bring a list, bring the pill bottles with you. Just because we have computers doesn't mean that has changed at all. So, so great point. So, when you're deciding a facility that you might take this patient to, has hemiplegia, hemisensory loss, obviously if you're in a small area, you've got one hospital, that's where you're going to go. But when you're suspecting stroke, intracranial hemorrhage, what kind of things are you thinking about when picking your destination?
Yeah, so I think that's something that's kind of become a lot more important for us to consider in EMS too, as things have kind of progressed in stroke care. And I think a lot of EMS is starting to do more specific LVO, so the large vessel occlusion type criteria and stuff that they're looking for, and using that on their transport decisions. Obviously, that's all stuff that's super dependent on where you're at and what system you're in and stuff. But making sure that you're clear on what your guidelines are as far as time frames and stuff, whether it's time from onset of symptoms and also time from time to get to whatever facility you're talking about is super important. Obviously, pre-hospitally, in any neuro thing, we have so little information that in regards to what's actually going on. So whether it's a hemorrhagic stroke or ischemic stroke, to what extent either of those are going on with this patient, we're not sure. So it's important to at least have good, clear criteria about what type of things we're looking for and what's going to guide us to go to, whether it's just the local closest facility or if we're going to take an extra 15 minutes drive to get to a comprehensive stroke center or what have you.
Great. So like you said, you're kind of looking for, you've got this patient that you're worried about, a neuro emergency, a stroke of some kind, either hemorrhagic or ischemic, and you're looking for what stroke centers you have. And if you're in a city that's separating primary stroke centers versus comprehensive stroke centers using some sort of large vessel occlusion screening tool, then maybe that'll help decide where you go. So great points that, that just because it's the closest hospital might not be the most appropriate in a place where you have a lot of options. So, and then finally you talked about stroke, doing a stroke screening tool. I think a lot of people right now are using BFAST for stroke screening with the idea that the FAST exam that we used to do doesn't always do the best of identifying these like posterior circulation strokes. So the BFAST stroke scale is kind of helping us out a little bit, try to catch some of those. So could you walk us through BFAST and how you would assess this on the patient you've got here?
Yeah, for sure. So yeah, that's something that's, again, with kind of advances in stroke care and stuff, it's been really big for EMS. Is we got to make sure we're up on these things and make sure that, again, we're familiar with, BFAST being what I'm most familiar with, and I think what a lot of places are using. Just to make sure that we're on the same page with the facilities we're transporting to and stuff is really big. So for the BFAST, it's, again, super simple, especially if you're already familiar with the FAST exam or really any of the Cincinnati stroke scale, any of that stuff. It's really just kind of looking at so B being balance. So a sudden loss of balance would be concerning. Eyes, sudden loss of vision, or potentially any gaze deviation, things like that. F for face, again, as like before. So any asymmetry, whether it's at rest or, when they're smiling. Arm, so the A for arm, meaning, sudden arm, leg weakness, numbness. Any abnormal, again, sensory, just as important as motor in a lot of cases. Speech, so did their speech suddenly become slurred? Are they having trouble speaking? Are they not understanding what you're saying too? Again, really big thing. It could be that they're just having a completely sensory or just a receptive, type of aphasia. So speech is a big thing to really kind of hone in on. Are they understanding what you're saying and everything? So besides just, are they able to repeat what you say, or are they able to speak clearly? A little more to that. And then time, T for time or terrible headache. Again, last known well time is super critical and something, especially that EMS needs to make sure they're on top of. And kind of adding that terrible headache thing, especially talking about, intracranial hemorrhages and stuff. I think it's even more significant in those cases where, could have someone who's got this thunderclap headache or the worst headache of their life that started all of a sudden, is obviously very concerning for, subarachnoid or any type of neuro, something in the brain, right?
Yeah, for sure. Yeah, I find that, for me, the most difficult thing to kind of assess here is balance. You have these people that are, they've been unsteady with their gait for, 15 years. So how do I know that, balance is new, or balance is something I should be concerned about? Kevin and Nico, I don't know if you guys want to share some tips for how you like to assess this, or how you, try to get other EMS providers that you might be working with, to assess for balance.
Yeah, I think so. I'll say quickly, as far as, pre-hospital and stuff, we're not really in the business of making people walk to the cot, hopefully. But it's always a good idea, I think, to anytime if you're even just pivoting a patient to the cot, kind of pause for a second and kind of see how steady they are. And then also obviously taking into account, what's their baseline. If they're using a walker at baseline, or they're completely, wheelchair bound at baseline, that's a whole nother thing. But are they swaying and stuff, even with their eyes open? That's concerning. And then obviously just asking, do they feel, unsteady abnormally?
Now, granted, for me, I typically have a lot more people with me, so I will try to make these people walk from time to time. But for those older folks that might not be able to walk so well, even simple things like looking for nystagmus in the setting of dizziness might be able to give you a little bit of a better idea. We talk in like the NIHSS scales about finger, nose, fingers, and heel, shin, heels. And sometimes these can lead us in the directions that we're going for.
Great. Yeah, I think for me too, the other thing I would say I like to teach paramedics is, to Kevin's point, if you're going to have somebody stand up to transfer them to the cot, just have them stand up and see how they do. Or another thing would just be checking for truncal ataxia. So having them like cross their arms across their body, sit up so they're not leaning on anything, and just close their eyes and seeing if they, are able to sit up unsupported. And certainly, like you guys had mentioned, like making sure that this is something that's new and not something that they've had for a long time. So, all right. So Nico, go ahead.
Sorry, no, you're good.
No, go ahead.
I was gonna say it's other stuff. You can certainly do that, in the ambulance too. If you're doing a more detailed assessment, once you have a little bit more time and things are calmed down, you're on the way to the hospital. Heel, shin, and finger, nose, stuff like that are all certainly could tell you important stuff. So,
yeah, just don't stand up in a moving car, though.
Try not to.
That might complicate your assessment a little bit. I don't know if I could do that appropriately. So Nico, so you're working in the ED at a local community hospital. And let's say that, we're not in a big city where you've got all these different stroke centers, you're just kind of the one shop in town. And Kevin brings this patient that we talked about to you. One of the most overlooked but extremely important pieces of care for this patient is really a good handoff. This patient in particular is going to have multiple handoffs throughout this initial phase of care, and making sure that we do this successfully is not only going to benefit this patient, but really build good habits for all the patients that EMS is bringing to the emergency department. So, as a physician who's receiving a handoff from EMS, Nico, what do you think makes a good EMS handoff?
I'll be honest, this is a really difficult thing, and I think one of the hardest things in all aspects of medicine. No matter what field you go into, everyone has their own style of handoff. EMS to me to the inpatient team, subspecialists or surgeons, and for the most part, it'll usually work okay. I also want to emphasize it's just okay because there's so much that gets missed, particularly in patients that have time-critical diagnosis or are critically ill, kind of like these stroke patients. Well, back in 2001, the Institute of Medicine straight up pointed out that as a whole, we're pretty bad at this, and often it's where patient safety fails first. From there spurred a litany of new research regarding patient safety goals and handoff tools, which, by and large, no matter what anyone might think of them, generally lead to better outcomes and easier transfers of information. Stepping off that soapbox and answering the original question, some level of standardization is what's most important. I don't particularly care what tool is being used or if it's tailored to a specific complaint, but hearing it in a similar pattern from these agencies, at least on the front end of the report, can be crucial. For example, a lot of agencies have recognized are moving towards the missed or demissed handoff, which I think is great. One thing some agencies have done, especially if they're already leaning towards the stroke call, is giving me the most pertinent information up front. The age, the last known normal, whether they're on blood thinners or not, if it's known, a blood sugar, a set of vitals, and whatever stroke score their agencies decided to use, kind of as Kevin alluded to, the race, the BFAST, the Cincinnati, or whatever exam findings might be needed. And finally, also, as Kevin mentioned, our pre-hospital friends have something we'll never have access to and can be really important. Really, what did that scene look like? Pills everywhere, a gas generator running in the house, a random dead animal found at the same time, crazy writing painted on the wall. These can all expand our workup from what might be an internal cause of a medical issue to an external cause, such as environmental or toxicologic exposures.
Great. Yeah. And I love the idea of a standard handoff that really kind of gets to the point. I think the days of, hey, let me give you this report. That's me just kind of summarizing my 20-minute call in 2.5, 3 minutes are well past us. Kevin, anything to add? Anything that, from the perspective of an EMS provider that hospitals can do to ensure that you've got a great environment for an adequate handoff?
Yeah, I think, especially in cases like this where, more and more these days we're, maybe trying to give a quick little synopsis just on the way to the CT scanner, even from the ambulance bay. It's important to make sure that we're giving them the information they're expecting in the order they're expecting. So things like the missed or demissed acronyms help with that, and that works in every call. So it's just good for communication overall, regardless. And then just making sure that we're very clear with the bottom line upfront type of things. So make sure that we're telling them the most important things that we know they need to know, and anything else that we're thinking that maybe they should keep in mind, we're telling them that upfront. And I'd say just finally at the end, once things kind of calm down, whether it's patients in the scanner or you just have a second to kind of step aside, whether it's the provider or the nurse or both, ideally, just kind of make sure that you're very clear about everything you said and kind of just laying it all out again, make sure it's all communicated.
Great. Yeah, one thing we do at our hospital for trauma patients that I really like is the handoff happens to the whole trauma team before the patient's even moved off the EMS cot. So, we found that if once people are slid over to the bed, somebody starts to work on the patient and isn't really paying attention to the handoff anymore. So especially for these really sick patients where you've got a whole team there ready to receive them, that's a good way to kind of make sure that everybody's focused on listening to what the EMS provider has to say to make sure that information is well received. And you could do the same thing, walking back to the CT or just kind of before transferring to the CT scanner. So, so Nico, let's say that this handoff's taken place. Kevin did a great job presenting this in a MIST format. What are your initial goals and plan for this patient, knowing what you know from Kevin's handoff?
Well, First things first is I quickly go through my own differential as I reassess the patient and see whatever's changed between the time of contact with our EMS provider and now. And in those times, I determine what do I have to do now and things that I think can probably wait. Now, you brought up trauma, which I think is important because we generally think about the ABCs associated with trauma apply to just trauma patients alone. But I found that they're pretty helpful to do in the undifferentiated medical patient as well. And considering with practice it can get done in under a minute, I think it's still a worthwhile thing to do. For the kind of patient we're describing, it's also good to try to get a good neuro exam, preferably before I decide to intubate them if it's something I need to do. Now, in the handoff of this particular patient, it becomes a lot more clear that something here is going to be in the brain, and so long as the sugar is normal, and if the risk factors are high enough, even if the sugar is abnormal, I'll set off the stroke code. Now, generally, we all know in emergency medicine that we play this game of very, very high sensitivity at the expense of specificity. In other words, I'm okay with being wrong and erring on the side of aggressive overtesting for such a time-critical and debilitating diagnosis. And I think most hospital systems and neurologists would agree. In other words, I need this person to go to the CT scanner as fast and safely as possible to determine if it's a bleed versus not a bleed, an LVO versus not an LVO, and whether this person is a candidate for thrombolysis, which can be within 3 to 4.5 hours of symptom onset, which is institution dependent, or a thrombectomy candidate, which has generally been agreed that it's up to 24 hours. In this case, I'm going to find this person has an ICH, or an intracerebral hemorrhage, and given the crazy high blood pressure and the dense symptoms presented, it would have been one of my earlier thoughts from the start.
So once you identify that intracranial hemorrhage, what are you focused on now?
A couple things here need to occur, and though I know I'm numbering these out, they're really occurring in tandem. First, I need to determine what kind of bleed and where it is, since the initial management can vary with the end result being the same, which is neurosurgery consultation and transfer to a higher level of care. Though it's worth noting with all the recent talk about the new brain injury guidelines, or big guidelines, the future of this might change, but we're not there yet. Second, similar to any trauma, the goal is to stop the bleeding. This particularly means anything to decrease the risk of bleed expanding, and this falls into two flavors. First, it's the reversal of the coagulopathy, which is why it's so important to get the medical history and whether or not these people are on blood thinners or not. These patients who might be on heparin should be receiving protamine sulfate. Those who are on warfarin receiving vitamin K and prothrombin complex. Those on 10A inhibitors, which conveniently have the letter X in all of their names, Xarelto, rivaroxaban, apixaban, receiving PCC or andexanet alpha, and in the rare occasion of the patients on the direct thrombin inhibitors such as dabigatran to receive the rarer idrisizumab or again PCC. Some of these reversal agents may be a bit more rare, so in a pinch, if you don't have access to these things, FFP might be a good option. It's also worth considering in the patient who has severe thrombocytopenia is platelets. Now, the jury is still out on whether there's a benefit to prophylactically giving platelets to patients on antiplatelet therapies such as aspirin, clopidogrel, or ticagrelor, so I typically discuss this with the neurosurgeon I'm talking to. And finally, another way to attempt to decrease the hematoma expansion is, of course, decreasing the blood pressure. This one is up for some debate, but in general, the recommendation is to aim for a target goal of a systolic blood pressure of 130 to 150, as there may be some proof that it improves functional outcomes. This is typically going to be best managed using a drip, as it's a little bit more consistent and expected of blood pressure management. Now, in the off chance we find out it's a subarachnoid hemorrhage, I'll typically give levetiracetam as a prophylaxis to seizures, as an active seizure will definitely worsen this outcome. And if there's any concerns for herniation, which kind of is being described here with the dense weakness on one side, would consider the use of hyperosmolar therapy in the forms of hypertonic saline or Magtol as a bridge to getting to their point of definitive care, which is not in my emergency department, as fast as humanly possible.
Great. And I love your point about, in particular, about thrombocytopenia. I think that's one that's easily overlooked. I think everybody, thinks pretty quickly to reverse the anticoagulation and decrease the blood pressure. But the thrombocytopenia is something that, usually that CBC isn't back by the time it's a bleed, and you can kind of easily overlook those platelets if you're not thinking about it. If you want more information on the emergency department management of this, we did record another episode of this podcast that is a really big deep dive into the emergency department management of these patients. So let's say now, Nico, that you're working at a community hospital that's not equipped to take care of these patients, and you need to get the patient out the door and transfer to a local tertiary care center. So the time it takes for you to receive this patient in the emergency department from EMS, diagnose the ICH, and get the patient accepted and out the door en route to another facility is called the door in, door out time, or the DIDO time. Now, the AHA suggests that the DIDO time for ischemic stroke should be less than 90 minutes for greater than 50% of patients. And there aren't formal time recommendations for DIDO for intracranial hemorrhage, but the principles are the same. These are time-sensitive diagnoses, some of which may require some emergent interventions and ICU cares. So, Nico, how can you work to minimize the DIDO time for this patient and for ICH patients in general?
Honestly, this is very difficult, but it's come down to great collaboration and kind of a lot of preparation. The real answer is that it comes down to the administrative level, ensuring you have the infrastructure to manage said events. And though it sounds obvious, I've worked in places where I've seen the entire process fall apart in real time. Things like functioning networks to speak to your teleneurologist, where the internet just crashed randomly and we had no idea how to manage the backup aspect to it until we found out much later that there were backup phone lines, which staff should all know about for when these network errors occur, as well as staff knowing where supplies are. Knowing also what your facility may or may not be capable of at any given time, i.e. whether you have ICU or OR availability and whether or not you have transfer agreements with regional tertiary care centers, plays a huge role in the management of these patients. And on the boots on the ground aspect of it, oftentimes running mock codes can at least help unearth these areas needed for improvement to better patient outcomes.
Great. And I think something else to think about is, how can you kind of work in serial instead of working one thing after the next, So the second that you've got an ICH and this patient's got to go out, as soon as you've identified that, because you're sitting in the CT scanner and you see the bleed as the image is coming through, you can already start to make the phone call to get this patient get this patient transferred over while you're doing all the other management things. I have seen this happen where you identify the situation and then you do all the things that need to be done for the patient, and then you make the phone call to get the patient transferred. But it really does take a while for patients to get accepted at facilities and then to get EMS en route, to get them to the facility to bring the patient to where they need to get. So the more that you can, start some of that earlier on by making phone calls early, getting the process going as early as you can is the best way to really decrease this DIDO time, in addition to a lot of the preparation and the things behind the scenes that Nico mentioned.
Oh, absolutely. And when we talk about minimizing DIDO times, if I'm in these situations where I'm in a remote location or a critical access hospital, as you mentioned, kind of deciding on early transport is a must. Most of these people that look like they have an LVO or an ICH, i.e. high NIHSS scores that you can see from the door, honestly, just start the ball rolling. It's easy enough to get the secretaries that you have online to start the transfer arrangements, find out which hospitals they're going to, and whether the CT shows no bleed, a small perfusion deficit, or large, I know this person does not belong in my emergency department, and finding a site of definitive care is a must. As you mentioned, this process can be really long, especially in an era now where EMS, like interfacility transport times, for certain less critical conditions can take hours. Earlier the recognition and the need for transfer, the better.
Yeah, and I think sometimes emergency doctors and me in particular, I know if I'm going to transfer somebody out, I do kind of feel like maybe there's a little bit of internal pressure, and maybe by bringing this on myself to make sure that I look like a good ER doc and that I've done all the right things for this patient before I, tell somebody else about it. I don't want to be judged as being an idiot, but I think again, really kind of focusing on, I can do all these things, while everything else is going on. And you're right. If I've got a high NIHSS and I'm really worried about this, how can I make this phone call, ASAP and get things working. So let's say that, you've got this patient accepted, rapidly, and you've called EMS, and now Kevin's working on his helicopter job for his critical care flight program. And he's going to be the one that's flying this patient from Nico's emergency department to the tertiary care center. So Kevin, from the perspective of the flight medic, what are things that the sending emergency department can do to help you minimize the amount of time that you're on scene in the hospital?
Yeah, for sure. So I'd say as much as possible, just kind of have the team ready and available when we arrive. We know, especially in smaller places, you could have a million things going on. You could have another patient coding in the room next door, of course, and so it's not uncommon for the provider, ED, not to even be able to speak with us. But especially if that's the case, just make sure that the nursing staff and everyone else is well prepared to at least give us as clear of a report as possible. So when kind of as we were saying before, though, we're very well aware of the fact that there's going to be a lot going on, and that's the business we're in transport, critical care transport stuff, and really kind of in most cases, the sicker the patient is, the less information we're going to have. So we certainly understand that. Also, as we're taking reports and getting information from you guys. And just expect us to ask some questions too. We're going to want to work quickly. It's not uncommon for us to make sure that we're being efficient, and oftentimes that means taking verbal report at the bedside obviously is ideal, but even at the same time as we're doing some initial assessments and putting the patient on the monitor, transferring any trips and stuff to our equipment. A lot of times that's all done at the same time, just in the interest of time. But expect us to ask questions. It's, again, especially if it's not the provider in the room able to speak with us, we pretty often, things that can that come to mind that I find myself often asking, especially in like a intracerebral hemorrhage type of situation, will be where is the bleed specifically? What kind of bleed is it? Oftentimes we'll just get like, I don't know, they have brain bleed. Where obviously, that tells us something, but we need a little bit more specifics than that. That's really going to guide where we're going with our care as we're getting them to the next facility. And kind of along the same lines with that, did the accepting physician have any specific requests, whether that's specific meds they'd like if available, whether that's reversal of certain anticoagulants and stuff, or if that's they prefer nicardipine or labetalol or what have you, and what are the blood pressure parameters they're looking for. There's obviously some pretty standard ones, and that's kind of what we'll fall back on. We have guidelines, at least where I work, we have guidelines that are going to lay those out for us, but it's not uncommon to have specific target blood pressures and stuff for us to be shooting for a specific patient. We're obviously more than happy to continue that if that's what's going on with that patient. And I think kind of another big thing that we definitely want to know is, especially again, in a cranial hemorrhage patient, oftentimes they're getting beta blockers or calcium channel blockers and stuff. And we really do need to know, especially if we're coming in very early on and you're just starting meds. Let's say we walk in, they just got 80 milligram push of labetalol or something that someone completely forgot to tell us about. And then we're starting nicardipine 2 minutes later and their blood pressure starts to drop really quickly. That's definitely going to kind of play into how we're going to be managing that patient. So we really kind of need to have a good understanding of the big things that are going on in the physiology of the patient we're grabbing from you. So we're going to ask a lot of specific questions that are going to be important in our care of the patient. So just being ready for that as much as possible, I think it's big.
Great. So again, just really emphasizing the importance of a good handoff where good information is shared, because of how much that impacts the care that you're going to provide, en route. Anything in particular that you're going to need to make sure is in place before you leave the emergency department and get in the helicopter? Yeah.
So, and this will, I'm sure, differ in different areas and different systems and stuff, but obviously we need to know that the patient we're picking up is accepted at the facility we're going to, and we need to specifically know where we're going. It may seem obvious that when we get there in a helicopter, someone's going to meet us and know exactly where we're going. That's not always the case. So it's, again, important that we know, specifically where that patient's going, because oftentimes, especially in stroke patients like this, we could be going right to an OR, we could be going to interventional radiology or the neuro ICU, all sorts of different places. So as much as possible, having that very clear, and being aware that that may change, obviously, while we're on the way there, but just making sure that we know where we're going and who we're giving the patient to. Paperwork and stuff, EMTALA forms, everything like that is going to be very dependent on, where you're working, but just make sure that that stuff is available, because that's some of the few things that may be absolutely required before we can take a patient legally. And then other than that, I think something that comes up a lot, especially these days with EMRs and like Care Everywhere and things like that, where even outside facilities or outside agents or different hospital programs can access patient records. In some cases, a lot of times people assume that we don't need any paperwork or any patient charts or anything. And I'd say overall, just assume that we need everything printed out. As much as possible, just kind of print out anything from the current visit with that patient, any history they have, any meds and stuff that you have on file is super important. And then obviously if it's available at that point, any reads from radiology on the scans, just written out would be great. Something kind of along those same lines that comes up a lot too is imaging. So it used to be that we always had to bring a disc with us, and that was huge. They were always expecting a disc when we got to a hospital with that imaging on it. These days, most of the time, they're able to push it through PACS and stuff. If there's any question whether or not that's going to work, just kind of, I'd say, be on top of making sure that those discs are being made really quickly. There's a lot of stuff that's, that can be helpful for us, a good detailed HPI and stuff that's already typed out would be great. But other than that, it's not really, there's not a lot of things that should be delaying us too much.
Great. And I think you're right that sometimes these electronic health records can fail, and you certainly don't have access to an electronic health record, while you're in flight. It's not the Epic or whatever system that, that the health systems might be on. And as a critical care provider, you are interpreting blood work. You might be using that to decide how to manage somebody en route. So that stuff is important for the critical care EMS transports.
Absolutely.
So while you are, go ahead.
Sorry. No, I just want to say, so also I would definitely say that it's, make sure that you're communicating with the team that you're giving that patient off to. If there is any sort of a delay, whether it's you're waiting on oftentimes it's something like we're waiting on a medication to come up from pharmacy. And in a case like this, it could be that, they're sending PCC up. And if that's a 2-minute wait, that is certainly worth it. But if they're waiting for a pack of platelets, which we carry to come up, there's no point in us waiting for that. We'll just give ours. Or if they're waiting for 40 pages of a biopsychosocial to print off, we can certainly tell you, don't worry about it. We're just going to get going. So I think, again, going back to communication is really big. Just make sure that you're aware of, or everyone's aware of, if there is any sort of delay, why that is, and if it can be avoided.
Yeah, that's a great point. And I think we all know how the one medicine or the one test that's going to take 2 minutes ends up taking 15 or 20. So
right.
That's a great point. So while you're en route with this patient, what are you kind of worried about? What are your care priorities? Are there things that are difficult for you to manage in flight that you might make sure are set in place before you leave?
Yeah. So, in any patient like this, the number one thing is anytime we're putting someone in an aircraft is airway patency. Is kind of the first thing we're always super concerned about. We tend to be a little bit more aggressive with managing airways before we get into a helicopter than we might have to be if we're on a ground ambulance, just given, space and resources and ability to, assess the placement and everything like that accurately. But we, in a case like this, we're going to make sure that we're kind of communicating any concerns we have with the sending physician. And if we're worried about the airway patency, we might be on kind of leaning toward taking the airway. That said, we are well aware that, it's certainly less than ideal to have a patient that requires some level of sedation and stuff. And it's obviously going to hinder ongoing neuro assessments and everything. So we're not going to take that decision lightly, and we'll certainly talk with any sending physician while we're there. to make that decision together. But so that's kind of a big thing that we tend to think a lot about, that we try to avoid having to do emergently in the aircraft. So, if a patient is, starting to lose their airway, we don't want that to happen completely in the back of the aircraft. It's not going to be in the patient's best interest. Other stuff that we might be considering, while we're in flight, or that we might need to take care of beforehand. Again, it's just making sure we have any meds and stuff. If they're going to get PCC, we can certainly give that and everything, but that's obviously something we don't carry, but is vital for the patient. So is that stuff we need to make sure we're getting, so we can be providing that while we're flying.
Great. So, all right. So I think this was a really great discussion on the EMS management of these patients, both the pre-hospital and their facility, as well as a great conversation about some ED, high yield ED tips, and really some discussion and suggestions for how you can really work on improving your dido time locally. So huge thanks to Nico and Kevin for being with me here today to talk about this. So Nico, and then I'll give you a chance, Kevin, if you could have kind of one big takeaway from this podcast for everybody, from your perspective, what do you think that would be?
The medicine for the management of ICH ischemic strokes will probably change in the future, and this is the nature of medicine. But the whole talk here can really be boiled down into really cleaner lines of communication and practice. For all of us that have ever taken any type of cardiac life support course, you know that they really nail the notion of the chain of survival. Strokes, whether ischemic or hemorrhagic, are no different, and though there will always be exceptions to the rule, stroke management should be as regimented as possible.
Great. And then Kevin, what about from your perspective as an EMS provider?
Yeah, I certainly agree. And we hit on it so many times today, but the importance of good, clear communication between everyone caring for a patient in all settings they might be going through in this type of a situation is so important. Making sure that as EMS providers, we're gathering and providing all that information that we're privy to in the pre-hospital setting, giving that to the accepting physician, and making sure that, again, if we're the ones then accepting a patient for transfer, making sure that we're getting accurate and important information and passing that along also. So I think, again, just communication for sure, and understanding the importance of it is really big for EMS.
Great. Well, thanks again, Kevin and Nico, and thanks everyone for listening. Have a good one.
Thanks for having us. Take care.
Thank you.
Thanks so much for listening today. If you would like to find out more about the AHA Hemorrhagic Stroke Initiative, please visit www.heart.org/hemorrhagic stroke. See you next time. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device.